Hello, in this video we're going to talk about the clinical anatomy of the knee joint. We'll begin by looking at an anterior view of the right knee. The knee joint is made up of three bones: the femur, the patella, and the tibia. Here is the femur. Because this is the right knee and we are looking straight at it, it has a medial condyle here and a lateral condyle here. The patella articulates with the femur. The patella is the biggest sesamoid bone in the body. Here is a smaller bone, the fibula, which does not make up the knee joint. Rather, it articulates with the tibia, the shin bone, which does make up the knee joint. The tibia has a tibial tuberosity here, which can get inflamed. When it gets inflamed, it is known as Osgood-Schlatter syndrome. Let's look at the same view of the right knee, so anterior view, but let's introduce some more structures. The knee joint is special because between the joints are fibrocartilaginous structures called menisci. There is a medial and lateral meniscus. These menisci are basically shock absorbers and help stabilize joint. It also has a role in distribution of the synovial fluid. The knee joint is further stabilized by many ligaments: the lateral collateral ligament here and the medial collateral ligament here. Here is the quadriceps tendon, which essentially attaches and overlies the patella bone and then forms the patella ligament. The patella bone has a patella ligament which runs and attaches to the tibial tuberosity, which, as we discussed earlier, can get inflamed and can undergo microavulsions, which is characteristic of Osgood-Schlatter syndrome. The patella ligament is actually the continuation of quadriceps tendons formed by the rectus femoris muscle and the vastus muscles of the thigh. Let us now look at the side view of the knee joint and introduce the bursa. The bursa are fluid-filled sacs that help reduce friction. So here is the femur, tibia, and the patella. The meniscus is the fibrocartilaginous structure that sits between the joints. Here again is your quadriceps tendon, which comes down over and basically encapsulates the patella in front, forming the patella ligament. Sometimes the patella ligament is also known as the patella tendon, and essentially it joins onto the tibial tuberosity. The knee has many bursa. Here are some common ones: the suprapatellar bursa, found above supra of the patella; the prepatellar bursa, found on top of the patella bone, below the tendons and skin; and then you have your infrapatellar bursa, which is below the patella. And there are actually two: one deep and one superficial infrapatellar bursa. Clinically, the bursa can get inflamed because of irritation between the skin and bone from overuse and friction. The prepatellar bursa can get inflamed. This is known as housemaid's knees. This is because supposedly housemaids are on their knees and scrub the floor. This will cause friction between the skin and the patella, leading to inflammation of the bursa between the two. Similar story, the infrapatellar bursa can also get inflamed. This one is known as the clergyman bursitis because of the same story, and friction between the skin and the tibia irritates the bursa, which lies between the two. Let us now take our right knee joint again and look at it from an anterior view, but this time flexed, so bent. In this position, we could introduce some other structures. So again, here is the patella on top because we're flexing the knee. And I'm not drawing the patella ligament here. Here in blue is the medial and lateral menisci. Anteriorly is the transverse ligament joining the anterior parts of the lateral and medial meniscus. The relevance of this is that it supposedly prevents the meniscus from moving forward, essentially. Inside the knee joint, essentially we have two important ligaments: the anterior cruciate ligament, ACL, and the posterior cruciate ligament, PCL. Remember this. They are named as to where they attach onto the tibia bone. So the ACL ligament is a ligament which runs from the back of the femur and attaches to the front of the tibia, front as in anterior, hence anterior cruciate ligament. The ACL prevents the tibia from sliding out in front of the femur. The PCL runs essentially to the back of the tibia from the femur. So the posterior of the tibia, hence posterior cruciate ligament. And the posterior cruciate ligament prevents the knee from hyperextending, so prevents the tibia from going behind the femur. Let's look at this from a different view, the right knee, from the posterior view, so from the back. Here again is the tibia, fibula, and intercondylar notch, or the femoral notch here. Again, here in blue is your lateral and medial meniscus. Coming off the posterior part of the lateral meniscus is the posterior meniscofemoral ligament, a ligament which is known to sort of have a secondary effect of a posterior cruciate ligament. And again, it comes off the posterior part of the lateral meniscus. Anyway, and here is the PCL, the posterior cruciate ligament, which comes and travels from the medial femur to the posterior lateral part of the tibia. The anterior cruciate ligament, on the other hand, comes from the lateral part of the femur and travels anteromedially to the tibia. Not only should you remember that ACL and PCL are named based on where they attach to on the tibial bone, but you should remember their course, so what direction they travel in. A good way to remember this is with the acronym LAMP, L-A-M-P. L as in lateral, the A as in ACL moves medially. M as in medial, the P as in PCL moves laterally. So LAMP might need some time to sink that one in. So again, I'm going to draw another view of the anterior knee and introduce some more structures. So here is the femur, tibia, and fibula again. The medial condyle and lateral condyle here of the femur. Here are your medial and lateral collateral ligaments. An important area of the knee to remember, which is located at the anterior medial part of the tibia, is the pes anserine, which consists of three muscle tendons: semitendinosus, gracilis, and sartorius. Behind these tendons sits the pes anserine bursa. Clinically, and quite common, is the pes anserine tendinopathy or bursitis, where there is irritation of the pes anserine tendons and or the bursa. Medial knee pain felt by climbing stairs and contracting hamstrings against resistance is a clinical feature. The reason is because these muscle tendons which attach to the pes anserine works as hamstring muscles. Finally, another important structure is the iliotibial band, which runs laterally over the lateral condyle and attaches to the anterior lateral part of the tibia. The iliotibial band, or ITB, can get irritated at this point here where it runs over the lateral condyle of the femur. This can be a site of friction, causing what is known as iliotibial band syndrome, or ITBS. ITBS is a common overuse injury seen in cyclists and runners. Here's a side view. We are looking at the right leg laterally. Here is the hip bone, gluteus maximus, quadriceps muscle, and the biceps femoris at the back. Here is the tensor fascia lata. 1/3 of the tensor fascia lata and 2/3 of the gluteus maximus muscle joins and forms the iliotibial band, which again attaches to the anterolateral part of the tibia. But keep in mind that the site of friction of the iliotibial band is the lateral condyle of the femur. The iliotibial band normally attaches to the tibia and helps stabilize and move the knee joint. ITBS causes a sharp pain at the lateral condyle when a person squats at 45 degrees, so bending, flexing, leads to the sharp pain. This pain can be elicited and is tender at this angle too when pressed upon. Now let us look at the posterior view of the right knee, focusing on what is known as a popliteal fossa. The knee joint is surrounded by many muscles that help stabilize the knee. The lateral head of the gastrocnemius is here. The medial head of the gastrocnemius is here. Plantaris, biceps femoris, and semimembranosus, just to name a few. And running just next to the semimembranosus is the semitendinosus, which attaches to at the anterior medial part of the tibia, remember, and forms the pes anserine. The popliteal fossa is essentially a fossa which contains things. And the popliteal fossa is formed by the biceps femoris superior laterally, superior medially the semimembranosus, inferior medially the medial head of the gastroc, and inferior laterally is the plantaris and lateral head of the gastrocnemius. So what is inside the popliteal fossa, you ask? Again, here is the iliotibial band and the biceps femoris. Now the tibia nerve runs here and branches to the common peroneal nerve or the fibular nerve, which then wraps around laterally around the head of the fibular bone. In the popliteal fossa, moving medially, we have the popliteal vein and then we have the popliteal artery, which are continuations of the femoral vein and femoral artery, essentially. Clinical significance. Well, the popliteal fossa can swell up due to many reasons. The most common being a Baker's cyst, which is essentially synovial fluid outpouching. This resolves by itself with time and does not usually require surgery. The other cause is a popliteal aneurysm, which does need surgery. When a person presents with a popliteal aneurysm, it is paramount to check for aortic aneurysm, as in 50% of cases, the person will have an abdominal aortic aneurysm. Finally, let's continue talking about the common peroneal nerve, or also known as the fibular nerve, which again is a branch of the tibial nerve at the popliteal fossa. As a common peroneal nerve, the fibular nerve wraps around the head of the fibula laterally. It branches to the deep and superficial peroneal nerves. The deep peroneal nerve supplies the anterior muscles of the leg and so is responsible for dorsiflexion and sensation in this area. The superficial, on the other hand, supplies the lateral part of the leg, so it is responsible for foot eversion and sensation around this area. Clinical significance: a foot drop can occur if there is damage or compression to the common peroneal nerve, also known as the fibular nerve. So let's draw an example. Here we are looking at the left and right legs and feet from the top. The left foot is normal and you can do dorsiflexion and foot eversion. However, let's just say there is a problem or a damage, such as a fracture to the head of the fibula. You can damage the common peroneal nerve. And here, obviously, we are looking at the right lower limb. So therefore, the right leg, the person who has damage to the common peroneal nerve on the right side is unable to dorsiflex their right foot and also cannot do foot eversion as well. They will lose sensation of the areas involved. So I hope you enjoyed this video on the overview, clinical anatomy of the knee. Thank you for watching.